this issue? Thank you.
Yes, we'd like to add that a placebo study would be a randomized control trial. And in that case, you cannot, if you select only people who avoided vaccination or who expressed an interest to not being vaccinated, there may be confounders introduced. They may, the children, maybe they had some experience with adverse events. So you cannot select participants based on their willingness. They have to agree to be part of either the study group or the control group.
Yeah, the point of a randomized controlled trial is that they have the exact same likelihood of receiving the placebo or receiving the vaccine. So the families would have to consent to that. And I think at a time where we're seeing the highest measles cases we've seen in many years, it would be concerning to ask parents to risk the chance that they would receive a vaccine that would not end up protecting them from measles, mumps, rubella, or varicella disease.
Yes, thank you. I do appreciate that answer. I would push back that in today's day and age, parents are asking for more such studies, and even if it is in more observational studies of vaccinated versus unvaccinated, that the populace would welcome this.
Thank you. Just one comment. One way to do ethical vaccine trials with the placebo control is to randomize them to the timing of the vaccine. Different countries recommend the MMR vaccine at different age. So one could randomize it, for example, giving them at age 12 months versus giving them at age 18 months, for example. So one can do randomized placebo control trials in an ethical manner to also then, so that's possible. But we'll continue with the list here. Dr. Blackburn?
Yeah, so in reviewing the studies on MMRV or MMR plus V, I noticed that they were designed with both vaccines given on the same day. Could you explain the rationale for conducting the trials this way? Wouldn't simultaneous administration of the MMR plus V yield similar adverse results, similar febrile rates as the combination product MMRV? Whereas evaluating these vaccines when separated by at least 28 days might provide clear insight into differences in potential adverse reactions. Given that the typical pediatric visit schedule includes visits at 12, 15, 18, and 24 months, there would be opportunities to administer the vaccine separately, and was that considered in the study design?
I'll ask if anyone in the SME knows, if SME room knows if that was considered in the study design.
The studies were designed to compare MMRV with MMR plus V because MMRV is designed to replace two vaccines or two injections in one. So the comparison needed to be between the what if we give them separately, what if we give them in the same syringe. But there are some studies, I mean, the same studies looked at comparing with the MMR arm, with an MMR arm or with a V arm. But the bulk of the studies were comparing the two vaccination options to see if you give one injection, would you get the same immunogenicity? How would the adverse events be? For the vaccines, then you don't need a combination vaccine. You can give MMR at 12, you can give varicella at 15, but that would not be replaced by one injection. The children will still get two injections.
Thank you, Dr. Pepper.
I have a question and a comment related to the vaccine information statement for MMR, MMRV. Is there language in that statement that prior febrile seizure or seizure of any sort after vaccination is contraindicated? I'm not sure. I somehow don't think that it's a contraindication. This goes to the informed consent issue. Also, I noticed, and to what Dr. Pollack mentioned about selection bias in potentially what we're seeing the data related to the second dose of MMRV at age 4 to 6 years of age. I noticed that the VSD data did note both febrile and afebrile seizures, although it was not statistically significant, but it kind of raises the question about non-significance, maybe because of selection bias, but also I feel like we need to address the assumption, it sounds like, that febrile seizures are largely benign. I'm not sure what the clinical significance is of these seizures. What do we know about them? And is this goes back to, should that end up being a contraindication to ever getting that vaccine again?
So with regard to the information statement, I would defer to the information statement, the information contained therein. If there's an SME on the line, perhaps someone could indicate if it's on there.
Go ahead. We have a comment, question on the vaccine information statement. Let me ask the IRD SME room to comment on that. Thank you.
Yes, we can report that the vaccine information statement for MMRV does contain a sentence that says, talk with your healthcare provider if you have a history of seizures or has a parent, brother, or sister with a history of seizures. Contraindications are set by FDA.
And also in the same VIS, under risks of a vaccine reaction, there is a bullet with a few sentences. Seizures, often associated with fever, can happen after MMRV vaccine. The risk of seizures is higher than after separate MMR and varicella when given as a first dose. And then your healthcare provider can advise you of the appropriate vaccines.
Thank you, Dr. Meissner.
Thank you. Thanks, Dr. Kuldorf. 2 points I'd like to make. First of all, febrile seizures occur in 3 to 5% of all children. They're common. And every pediatrician is experienced in febrile seizures. And we know that the prognosis is excellent. The major concern, as Dr. Kuldorf has pointed out, is the anxiety it generates in other family members. And that's entirely understandable. And it's a very frightening experience. But I think people are very comfortable in saying that a febrile seizure is not associated with any sort of impaired performance or neurocognitive development or school problems. I don't know if I can call it a frequent occurrence, but every pediatrician is quite familiar with febrile seizures. Number 2, the issue I think we're discussing, it really comes down to, should parents get 2 doses or should they get 1 dose of these measles, mumps, and rubella and varicella? And the disadvantage of giving 2 doses, or as was suggested, separating the 2 doses, is that we know compliance falls. And the advantage of combination vaccines is that children and adults are more likely to complete the vaccine requirements if it's given as a single dose. So the second, and then the argument against giving MMRV at 12 to 15 months is that there is this very slight increase in febrile seizure activity. And I think the way it is currently stated by the ACIP in the MMWR is quite appropriate. If a parent is more concerned about a febrile seizure, she can have the vaccine administered in different arms. If she's more concerned about reducing the number of immunizations by one dose, she can have the combination vaccine. And I think, as Dr. Oliver pointed out, about 85% of children are now receiving a vaccine in each arm, and that's fine. I think. I mean, I'm not quite sure where we're going with this discussion. I think that the current wording is appropriate. Over.
Thank you. And Dr. Asaf-Levy?
Yeah. So I guess I feel a little bit feel at unease, because it seems to me that we are making a lot of assumptions that we really understand what we are seeing. And I want to remind ourselves that we call, a lot of the time it turns out that we call different things the same just because we did not understand the underlying mechanisms that could be very different, but the way we measure them made us believe that we're actually seeing the same thing. So I think, just building on the comment that we heard before, it's not clear to me that a seizure, febrile seizure that comes after a viral infection is the same as what we are seeing here. And I think we need to investigate that, because if it's not, potentially our assumptions about the long-term and the short-term implications may not be true. So I think we need to adopt a little bit a safety approach that doesn't just limit ourselves to what we measure, but also recognize that what we measure is limited, and we need to try and understand the mechanisms. And I have to say, I'm listening to discussion, and my impression is that we don't really know what's going on, other than that the fact that a vaccine that has a higher level of antigen seems to cause more frequent events like this. So I would really encourage all the agencies that are responsible for this to really launch more investigations that include some measuring the kids that had seizures and following them long term. I don't think we can just stay with the mindset that safety of vaccines is limited to the 30 days, 40 days after vaccination, because the essence of vaccines is actually to make long-term biological impact on our body and give us long-term immunity, which is the benefit. But if we assume that the benefit is long-term, I think we also need to consider the fact that some of the adverse impacts could also be long-term.
Can I answer, Dr. Itzef?
Yeah.
And I thank you for that comment. I think it's a very well taken point, Retzef. My response is that febrile seizures are pretty well defined. We know, for example, that a febrile seizure obviously occurs when a child, usually less than 5 years and usually less than 4 years of age, has a fever. It's a generalized seizure. That is, it doesn't involve one limb or another. We know that it lasts, it's been defined as lasting less than 15 minutes, and usually they last just a few minutes. So they also do not recur within 24 hours as part of the definition. So we have a pretty reasonable definition of febrile seizures, and the vast majority of febrile seizures do not occur in association with vaccines, as we're saying. So just for one, I'm not sure putting limited resources into this activity will give us the greatest bang for the buck. I think that we're so familiar with, as a pediatrician for more than 30 years, we're so familiar with febrile seizures, and I think most pediatricians would say that the prognosis is excellent, apart from the emotional impact on the family. Over.
Thank you. We have time for two more persons, and then we're going to have to end so we can move forward to the statement from the vaccine manufacturer. So the next is Dr. Milholm.
Thank you. As someone, I'm not sure how many on this committee actually do an electronic medical record. I know that there's a lot of dependence on the ICD codes that are generated. And I've heard that some people consider if there isn't an ICD code generated on a certain condition of a child, then that didn't happen. I will tell you, as a practicing physician, the amount of time I can spend trying to look up ICD codes to make sure that every one of them is there and exactly the precise ICD code that the child has is often time prohibitive. I think that it's important that when we look at data, we look at clean data. And I think the cleanest way to have clean data is to have an ICD code that is febrile seizure temporally related to a vaccine. And then you have a febrile seizure that's not. If we're going to be looking retrospectively at ICD codes, I think this is very important. But I also encourage people who are not in clinical medicine, who are using ICD codes to generate research, that these are not perfect. These are not a perfect data set. So those are my thoughts.
Thank you. And the last now from Dr. Plesworth.
I just want to thank you, Dr. Meisner, for your comments and your clinical expertise on this. But I want to push back just a little bit and note that there is a study out there published in 2023, the long-term neurodevelopmental outcomes of febrile seizures and underlying mechanisms, that states both clinical and animal studies show that febrile seizures have detrimental effects on neurodevelopment that cause attention deficit hyperactivity disorder, increased susceptibility to epilepsy, hippocampal sclerosis, and cognitive decline during adulthood. However, the mechanisms of febrile seizures and developmental abnormalities and disease occurrence during adulthood have not been determined. So it goes on, but I think this is a topic that merits being put on the agenda at some point to evaluate as part of the safety work that we need to be paying attention to.
Thank you so much, and thank you for a very good discussion. And again, thank you for that presentation, Dr. Su. The next one is, I think we have a comment from the MMRV vaccine manufacturer. Are you on the line?
Yeah, can you hear me okay?
Yes.
Yeah, thank you.
Please go ahead.
Yeah, this is Rick Haupt. I'm the head of infectious disease and vaccines, medical and scientific affairs at Merck. And for the record, I'm a pediatrician and saw many children die from infectious diseases that included pneumococcal, Hib, and varicella. And now these are all vaccine preventable. I'd hate to go back in time to a period when we saw invasive diseases. ProQuad MMRV has been evaluated through well-designed, high-quality clinical trials and post-licensure effectiveness and safety. And those data have been shared with regulatory authorities, public health agencies, medical societies, and have been published in journals. This issue of febrile seizures, the slight increased risk after the first dose, was initially described by an observational study that we conducted with Kaiser in 2009. So this has been something that's been well described for 15 years now and has led to the current recommendations, which are that there is no risk for the second dose, so it's preferred to give MMRV for the second dose. But for the first dose, the preference is for separate MMR and varicella vaccination to be given. But the language allows for a provider and or family to select MMRV as the dose given in the first dose. As we've discussed this morning, that has led to about a 15% utilization, but the vast majority of children receive separate MMR and varicella at 1 year of age. It's important to note that evidence indicates, and major public health organizations and professional societies agree, that combination vaccines improve completion and on-time vaccination, leading to higher adherence and fewer delays in disease prevention, And recent CDC surveillance data reveal a troubling decline in kindergarten vaccination coverage, where rates for measles, mumps, and rubella, potentially serious and fatal diseases, have fallen below 95% threshold, which is required to sustain measles herd immunity. Considering these trends, any policy decision that compromises the clarity or consistency of vaccination guidance for MMRV has the potential to further diminish public confidence. I think that's really important in your deliberations, and I thank you. I can go back and answer some of the questions that you may have had for us. The one point I would make is that there was one question about what do we understand about the immune response and why was there a higher amount of antigen for varicella that was put in MMRV. And that's important to know. The increased antigen was only for varicella. There was no change to the antigen content for MM or R in the combination vaccine. And it's essentially related to what was needed to demonstrate an appropriate immunological response to show non-inferiority of the immune response of MMRV compared to the separate MMR and V. And it's very likely that this relates to local interference of the antigens when they're given in the combination product. That's all from me. Thank you.
Thank you. I would like to make one correction to make sure that the deserves the credit for finding that out. It was done through the Vaccine Safety Data Link and its rapid cycle analysis, where the CDC evaluates new vaccines with weekly data feeds. And it was detected, I think, after about 25,000 doses. So it was a very quick detection, and it shows the excellent work that people here at CDC and in this particular VSD is doing to monitor the safety of vaccine. Are there any other comments or questions on this presentation? Dr. Hibbelin.
A brief comment concerns that we are looking at a risk benefit of febrile seizures, which may or may not have long-term consequence, likely not, as compared to falling below a 90% coverage rate for herd immunity. And the consequences of that are devastating for pregnant women losing their babies, newborns dying, and having congenital rubella syndromes. And that it seems that we have to be very careful of driving this non-vaccination group below 90%. Appears we have to be very conscious that this may be driven by fear and may be driven by most people, the fact that most people don't think about, they think of vaccines being either good or evil. And either I should have my child vaccinated or not vaccinated. And they don't understand the discussion of the subtleties that we're going through. So if we make a major change in what has been a very vaccine campaign, I think we have to have a darn good reason
as to why we're making that change from what Corey Meisner out and access. We had better have a very good reason as to why we changed that advice.
Thank you. And I think we can move forward now to the proposed recommendations and a discussion of those. If we can get those proposed recommendations up on the screen, that would be great. I would like to stress that in this vote, we are not voting on any changes in what diseases children are vaccinated against, nor are we proposing any changes in the timing of these vaccines. So that's not part of the vote or discussions. One can have different views on that, but that's not part of what we're doing today. So the vote is on the pediatric vaccine schedule should be updated to reflect the following change. For measles, mumps, rubella, and varicella vaccines given before age 4 years, the combined MMRV vaccine is not recommended. And 2, children in this age group should receive separate measles, mumps, rubella vaccine, and varicella vaccines, MMR+B. And again, we are neither voting on children above 4 to 6 years because we know that there's no difference in the risk of seizures among those older children. So this is the vote, the proposed vote. And do we have the discussion now then, before we do? Oh yeah, okay. But we have the discussion now of this, and we are voting not until the end of the day after public comments. Dr. Stein?
Could you clarify how this is different than the current recommendation? Because that the 2009 recommendation sounds like the 2 separate shots.
So there's 2 main differences. One is that the current recommendation says that both are recommended with the preference for MMR+V. The other one is that some children get a second dose before age 4. For example, if there's an outbreak, a child might get a dose at 7 months of age, but then they have to be, because it doesn't have the efficacy, so it has to be, then get a dose again at 12 or 15. So then that's the second dose. So they will also, so right now, so they will also change so that everybody who gets the dose, whether it's the first or the second dose, it will be not, MMRV will not be recommended, whether it's first or second dose. Those are the 2 differences. Dr. Levi?
Yeah, so the way I think about it is, let's say that someone would guarantee us that the adherence would be the same. Let's just for the sake of discussion. It seems to me quite reasonable that most of us would think that the separate vaccines are better because there is some harm or adverse events are being caused in excess. I think some of us maybe feel more kind of comfortable that they know and they understand that it's just like a local impact of that event, and some of us are more concerned. But I suspect that if we would somehow be guaranteed that all things are equal between these 2 options, the adherence is the same, I think the choice would be clear. So that kind of brings to me, in my mind, the discussion to what extent we believe that 2 separate doses are going to have materialistic impact on adherence. And I'm not fully convinced which factor. We are all concerned on reduction in adherence to vaccines, but it's not clear to me that the fact that we see a reduction suggests that the reduction would come or would be affected by the fact that we separate these 2 vaccines for the first dose. In fact, I actually tend to believe more that safer and less adverse events are going to increase trust and adherence. So that, given that at the very best, I don't think we have good evidence either way, I would go with the option that seems to be safer, that also gives lower quantity of the antigen to the children. I think that that's something that makes sense to me.
Thank you, Dr. Petsworth.
I just want to clarify that currently 85% of the first dose is MMR plus V. So we're talking about 15% of vaccinations at 12 to 15 months is currently MMRV, correct?
Yes, that is correct. And I mean, I want to sort of give praise to the pediatricians because they have both options, but 85% is choosing to administer the MMR plus V because of the fewer seizures. And just an anecdotal thing, when my twins were vaccinated, I asked the nurse if it was the MMRV or the MMR plus V, and she said, "Oh, it's the MMR plus V because," and she gave us exactly the correct reasons for why that is the case, without knowing that I do vaccine stuff. So she knew her stuff, and of course the physician in the office knew his stuff. So I think we should praise the pediatricians and the nurses who are 85% are sort of trying to minimize these febrile seizures. I think we're actually a little bit ahead of schedule, so that's the good. Oh, okay, Dr. Meissner.
Thank you, Dr. Kulder. And let me make two comments here.